Hey, I want to pop on here real quick and have a discussion with you about something that came up with patients, often comes up with patients, especially if we're dealing with knee pain, hip pain, foot issues, but also low back pain. And if we're dealing with an upper extremity patient, shoulder problems, this topic comes up, and this is one of the first things that I cover with any type of student that's coming to do a rotation with us. So I've had undergrad students come do their rotations, had PT school students, first year, third year, all that stuff. And one of the first things that I ask them is when we're going through an evaluation with a lower extremity patient, we're doing the lower extremity screen, so gait assessment, squat, single leg squat, all of those types of things. One of the first things I ask these students is, what's pronation? Or did you see how well did they tolerate pronation? And when we're talking about a hip patient or a low back pain patient, the students automatically go to feet. Well, feet is pronation, supination is your foot, right? And I'll say, no, did you see what happened during pronation of the hip? And they'll be like, pronation of the hip? And I said, well, you know what pronation is, right? What three components make up pronation? So as you're sitting there right now, can you rattle off to me the three components that make up pronation and the three components that make up supination? Because if you don't know those and you don't understand that not only does the foot pronate, but also the knee pronates and the hip pronates and the pelvis pronates. So if you don't understand how all of that goes together, you're gonna have a really hard time helping low back pain patients, and you're gonna have a really hard time helping plantar fasciitis patients, ankle sprain patients, patellofemoral syndrome patients. So let's go over this really quick. And I'm going to go over the same thing that I go over with students and I go over with patients who have no medical background. So I would bet that once my patients get done seeing us, they can explain what's going on with their problem better than any PT in town, because PTs don't understand how to apply pronation, just like they don't understand how to apply neuromuscular physiology, and they don't have any clue how the law of reciprocal inhibition fits in with anything, because they didn't teach you the importance of pronation and supination in school. So here we go. So when I just said, tell me the three components of pronation, what are they? So pronation is internal rotation, flexion, and adduction. Supination is external rotation, extension, and abduction. Okay, so does that make sense? So if this is my foot, this is a foot, and it's pronating, so it's collapsing. So pronation is collapsing, storing energy. Supination is returning from collapse, so unsupinating, unpronating. So it's unloading and return, or using that stored energy to release energy. So if you don't pronate, you can't supinate. So think of that when it comes to orthotics. We'll circle back there in a sec. Let's finish up this adduction, internal rotation, flexion component. So foot is collapsing into adduction, internal rotation, and flexion. Well, if this is my ankle, this is my knee, this is my hip. So if that's doing that, so also my knee and my hip are also internally rotating, flexing, and adducting. So that's why you must pronate. So if you put something in somebody's shoe that stops them from pronating, they no longer can load, which means they can no longer unload. So every time you stop somebody from pronating, you are screwing up the whole chain of reaction that is supposed to be going on in order for them to function normally. All right, so now let's go supination. So supination is externally rotating, abducting, and extending. Okay, same foot, knee, hip. All right, so what should we be doing with these people that overpronate at the foot? Well, in my book, there's no such thing as overpronation. There's pronation too far too fast, because you cannot eccentrically load and control flexion, internal rotation, and adduction. So they collapse into that. They go too fast into pronation, and they undersupinate. So they pronate and they get stuck in pronation and they can't get out. They can't supinate. So that's not overpronation. You've been taught that wrong the whole time. It's pronating too far too fast and undersupinating. You're not supinating, because you can't control the load, you cannot unload. Or if you put something in the shoe to stop the load, then you cannot unload. So when I talk to people who come in, and we always take everybody's shoes off. So first thing they do, take your shoes off. You're coming in for tension headaches, take your shoes off. Impingement syndrome, take your shoes off. Low back pain, take your shoes off. Okay, so when they take their shoes off, I peek inside their shoes and see what they have in there. So if I see that they have orthotics, and this is a patient that's coming in for hip problems, low back pain, I'll usually ask them, well, how long have you been having hip and low back problems? Okay, 6 months. Okay, cool. So it's not unlikely to have these patients when I circle back and say, well, why do you have those inserts in your shoes? Oh, I have bad feet. I have flat feet. No, you have the feet that your genetics say you're supposed to have. Some moron who thought that they know more than your genetics know said that you have flat feet because they don't look like the pictures in the book of a normal foot, which is absolute bullcrap, and they've stuck an insert in there, okay? So if I say, well, how long have you had those inserts for your flat feet? Oh, about 6 months. So would the onset of your low back pain and hip problems coincide with the onset of you using something in your shoe that stops you from loading, which stops you from unloading, which puts more stress on your hip and low back because now your foot is not absorbing and distributing force appropriately? All right, so if you don't understand that pronation and supination happens at the foot, the ankle, the knee, the hip, the pelvis, all that stuff, you need to understand that, because if you don't understand that and you don't understand how to watch somebody break down somebody's gait, break down somebody's double leg squat, especially their single leg squat, because when we watch somebody's single leg squat, we are trying to assess their ability to load and unload, or their ability to pronate and supinate, okay? So if they can't do that before the visit, we're gonna break them down and figure out. So now the next step is, what muscles control pronation? So I already said pronation is eccentrically loading into flexion, adduction, and internal rotation. So now you have to ask yourself, what muscles get longer eccentrically contracting during pronation? Okay, so think about this. When your patients come in with patellofemoral syndrome and chondromalacia and subluxing patella, and the physician writes VMO exercises and IT band stretching, does that make any sense? So does the VMO help eccentrically control pronation? Not ever, not even close. What does? Vastus lateralis. That's why when you assess people and you break them down muscle by muscle, when you have the opportunity and the ability to do that, you'll find out 90% of the time, vastus lateralis is inhibited. Why? Because vastus lateralis has to lengthen as the femur is internally rotating, adducting, and flexing. Okay? There is absolutely no reason why you should be trying to strengthen the VMO. The VMO has absolutely nothing to do with patellofemoral syndrome, anterior knee pain, chondromalacia, subluxing patella, yada, yada, yada. Now, if you look at a picture, an anatomy picture, and you look at the VMO and you say, well, but wait a second, those fibers run in an orientation that would pull the patella medially so it doesn't sublux. Okay? So what you're looking at is a picture of picture anatomy. What you're not understanding is functional anatomy, which says that as the knee adducts, the patella is going to go wherever the least amount of resistance is and wherever the hip and the foot tell it to go. So if it goes too far too fast, because you're not getting eccentric control from the vastus lateralis and the gluteus medius and the gluteus minimus and the TFL and the gluteus maximus and the soleus and the abductor hallucis, if you're not getting all of those things to control pronation, that's when the patella will now be going places that it should not be going. That has absolutely nothing to do with the VMO. So that's why when I get students in, we break down the difference between picture anatomy, which is open chain pictures of what we think muscles would do, and compare that to functional anatomy as in watching somebody function and understanding what muscles are contracting eccentrically and what muscles are contracting concentrically and what angle each one of those muscles should be contracting. So when somebody says I have knee pain at 90 degrees of knee flexion, I know what muscles we test in 90 degrees of knee flexion with hip internal rotation. That's how easy it should be to evaluate somebody. So first, you have to understand biomechanics, pronation and supination. You must understand that pronation and supination happens throughout the lower extremity of the trunk. It's not just a foot thing. And that pronation is normal and that there's no such thing as overpronation. There's pronating too fast and undersupination, which would cause problems. Now it's up to you to understand which muscles did not control pronation, which allowed it to happen too fast and go too far, so now that we can't supinate. Okay, so hopefully that made sense. So when we do the webinar that's coming up on the first weekend of November, I have a feeling we're going to be doing a case study because we're going to bake this talk into that case study. I know that a lot of you voted for, you want me to go over neuromuscular physiology and do demos. Well, I can't talk about a case study without talking about neuromuscular physiology and including demos. So my goal here with this webinar is to have a patient, as I go through and show you what's happening, have the patient model what's going on, talk you through physiology, talk you through the demos, so you understand how that fits with a real patient. Because here's a problem that a lot of you are having. You're thinking that the 180 system is a tool that you can use in conjunction with all of your other tools. That is not the case. The 180 system is the tool that smashes your toolbox and gets rid of the rest of the tools. Because if you know how to use critical thinking to break down neuromuscular physiology in order to get to the root cause and reverse that, so now you have normal facilitation, normal mechanics, and now it's up to you to program their exercises to reinforce what you did with the 180 system manual therapy, then you can move forward. Notice I didn't say, well, sometimes we might stretch people, but at other times, no, stretching, they're hypermobile, so they don't need stretching. So sometimes we need to brace them or tape them or orthotic them. But sometimes that doesn't feel good and they want to have cupping and needling, so we do that. No. We do the same thing with every single patient. So if I gave you a talk on neuromuscular physiology and did demos, the problem is you then take that away and say, okay, well, here's some more tools to put in my toolbox to use as I see when I need to use them or when a patient asks for it. No, it's the all the time, every day with every single patient, all the time, without exception, tool that you use, which means you don't have time for the rest of the crap because you already figured out that none of that stuff works. That's why you're here, okay? So be ready for that. The first Sunday in November, it's either the 2nd or the 3rd, whatever it is. Pay attention for the release here so you can get your ticket and get in there. But that's what we're going to be talking about. And if you have questions specific to pronation, supination, why there's no such thing as overpronation, why there's no such thing as flat feet, all the nocebos and fairy tales that you've been taught forever so you can pigeonhole your patients and make them fit the broken medical model. If you have questions about that, post those down below and I'll get to those, and I will see you before the webinar, but I will for sure see you live in the webinar so we can go back and forth and you can ask questions. I can give you feedback and I can show you how easy it is to reinvent your career, to get your patients the results that they wanted, for you to have the career that you wanted in less than 4 months. I'll see you soon.